Good morning. Thank you to the organization for this warm invitation to present at the British-Ukrainian Symposium this year. My name is Sandra Schyns. I'm an anesthesiologist in the Netherlands, and in the next 20 minutes I want to address a few misconceptions in obstetric anesthesia, some of which are either true or false or unproven, and I try to bring some nuance in the ongoing discussions. They have all three to do with either timing, side effects, and complications of neuraxial labor analgesia. The first one is related to the interference with labor. The second one has to do with epidural-related hypothermia, or as people call it sometimes, epidural-related fever. And third, it has to do with postdural puncture, a headache and a complication which is often iatrogenic and where new evidence is reshaping the narrative. Well, the first statement and the first myth I want to talk about is that I still often hear that you cannot have an epidural after certain cervical dilation. I hear it from midwives, from obstetricians, and sometimes from my own colleagues in the middle of the night. They say that there is a specific point in labor at night that's often 7 centimeters cervical dilation, beyond you should or would not want to place an epidural. The question is why? And we have to address, is it safe to give an epidural at a later stage of cervical dilation? Does timing affect outcomes? And does it actually work when placed in advanced labor? I'll try to address some of these issues. Well, if you see the study I present over here. This was a study with 400 nulliparous women from China. What they did, they gave all women epidural analgesia with a low concentrated ropivacaine sufentanil mixture. At full dilation at 10 centimeters, women were randomized to either receive epidural analgesia or saline in the epidural catheter. And this design controls for the previous analgesic exposure, and it isolates the effect of continuous analgesia during the second stage. And what they find, quite reassuringly, that there were no significant differences between the groups in the duration of second stage, mode of delivery, in the episiotomy rates, in fetal changes of position, EPGAR scores, etc. They found a difference, though not statistically very obviously significant, that there was an improved maternal satisfaction in the epidural group. So continuing epidural analgesia into the second stage of labor is safe, does not meaningfully worsen outcomes, and is associated with higher maternal satisfaction. But we knew that already since 2005. It has been in the guidelines since 2005. And yet still sometimes women are told to push through it without analgesia. And it's part of our role as obstetric anaesthetists to be an advocate for evidence-based pain relief in the labor wards. So we have to be clear and consistent and provide analgesia when it's requested and not when it's convenient to us only. Now let's move to a broader question of epidural analgesia timing. What does cervical dilation have to do with it? Can you initiate epidural analgesia late in first stage of labor? This was a very large retrospective cohort group published in 2020, nearly 19,000 patients. They looked over the association of cervical dilation and the rate of prolongation of the first and second stage and the rate of instrumental delivery. Now first, what they found actually that there was a duration of labor was prolonged with an epidural. In PreMaCare, the total prolongation was almost 2 hours. And especially in the second stage, it's quite big compared to the multiparous women, where the second stage prolongation was 8 minutes, but still statistically significant. So this is important information for our informed consent conversations. Women should know that labor may take longer with an epidural. But the critical question is, what does it mean for the delivery mode? Because actually, to be honest, in the Netherlands, once there is an epidural, oxytocin augmentation is more often initiated. So this is quite a confounding factor, actually, in most studies. But what does it really mean for the delivery mode? And the study looked at this. Also, they looked what the odds ratios were for instrumental vaginal delivery, according to the cervical dilation at which time the epidural was sited. And they controlled in the regression model for maternal age, fetal sex, head circumference, and birth weight. And actually, none of these individual dilation groups, 8, 9, or 10 centimeters, reached clearly significant result difference in premiparous women. And in multiparous women, you found the 9 centimeter dilation and initiation of epidural analgesia, a significant difference. But if you look at the wide confidence interval, this is most probably due to small numbers, selection bias, and there must be a poor fetal descent and anticipated difficult delivery being the problem. The take-home message is that for most women, the dilation at which the epidural is placed does not independently predict and strongly predict instrumental delivery. The question remains if a late epidural would be the right choice, because as you all know, at first stage, the pain is mostly visceral, and it's transmitted through thoracic 12 to lumbar 1 to 2, and it's a visceral pain. And an epidural catheter at L2, L4 provides excellent coverage. But the second stage, it's the actual damage, the traumatic rupture of tissues in the perineum, vagina, and rectum, which causes the pain. It's a somatic pain, and these sacral nerve roots are further from the epidural catheter tip at L2, L4. They are large, they are densely myelinated, and it takes time. If you start an epidural late, it might struggle to achieve adequate sacral coverage and adequate pain relief in the second stage of labor. So the discussion is actually, should we look how to initiate an epidural at a very late stage in labor? Because if we would choose a combined spinal epidural, in which we also add first, before inserting the epidural catheter, a spinal injection, a small spinal injection with an intrathecal low concentrated dose of local anesthetics with or without opioids, it gives a speedier onset, it gives excellent sacral coverage, and if you concentrate the solution very lowly, there will be a minimal motor response. And in this perspective, the dural puncture epidural, which is becoming quite popular in some hospitals in the United States, that's where you intend to do CSE, but in which you do not inject real drug into the intrathecal space once you have perforated the dura arachnoid complex. And the idea is that somehow there is some infiltration from the epidural drug delivery into the intrathecal space and a little bit faster. But the evidence is not there yet to see if this is any option. So actually, we can state that epidurals significantly prolong labor, but with low concentrated solutions do not increase instrumental delivery rates. At least this is based on the big meta-analysis by Amin Somua, and she collected many studies through the years in which the epidural versus non-epidural was compared for for analgesia, but she also looked at effects on instrumental delivery. And if you see in a previous meta-analysis, there was a significant difference on the rate of instrumental delivery. And also in her second version of the same meta-analysis, there was a significant difference. But when she only took the studies which used low concentrated local anesthetic solutions, there was not longer a significant difference in the incidence of instrumental deliveries between the epidural and non-epidural groups. But still, the discussion is ongoing, because this meta-analysis looked actually at analgesia first, and these groups, they noted that women with epidurals had more often hypotension, motor blockade, and more often first and second stage, as we have seen before. But also, what's very interesting, women with epidurals had more often oxytocin augmentation, and how that affects instrumental delivery rates. It's not clear. This is a sort of a complex causation, association, confounding mix in which solutions still have to be found. Now, if you look at instrumental vaginal delivery in the previous big database, the 19,000 patients we had, and you can see that they found an instrumental delivery rate which actually double in women with epidurals. Highly significant. But this seems alarming, but these are crude ratios, and these have not been adjusted for all the things I told before, the pain severity, also the labor dystocia, indications for epidurals. Because we know that women who request epidural analgesia are not the same women who don't need an epidural. So there is confounding by indication definitely playing a role. So looking maybe different at data can find an answer to the question if epidurals are related with instrumental deliveries. These studies were done in the Netherlands, and this was in a time when labor epidural analgesia was introduced to be available in all hospitals, and the rate increased quite quickly to 22%. And what you see in these 10 years is that even though there was a doubling of the epidural rate, there was actually a reduction in primiparous and nulliparous women. There was a reduction of the instrumental vaginal delivery rate and a little increase in the caesarean rate. And this difference couldn't be seen either in the multiparous women. So that's reassuring. But also from the Netherlands came a recent new discussion started by the group of Groningen, where they looked at the national database of birth registry, and they found that the intrapartum epidural analgesia was associated with an emergency delivery for presumed fetal compromise. And this was quite alarming. They made a lot of attention to this finding, that it was more than doubled compared to alternative analgesia. But we should realize that this is a registry study which cannot distinguish between epidural analgesia causing fetal compromise versus epidural analgesia being chosen in women who already had complicated labors, where fetal compromise is more likely, thus confounding by indication. But what they did find, though, was interesting, that actually let me see if I can move the slide, that actually the differences were mostly found in the small for gestational weight groups. And this is quite strange because even though it's a registry and there is a lot to be said about the quality of the study, that both in nulliparous and multiparous women, you see especially the difference striking in the smallest weight babies. So, okay, this might mean something. We have to look further into that. Well, they did themselves by using another database. They used the Ravel multicenter randomized controlled trial database to do a post hoc analysis. This study compared analgesia between remifentanil, PCA, and epidural analgesia. And they randomized women, so there was actually no confounding by indication. But in the secondary analysis, they dropped the crossover patients, which made comparison of these unequal groups completely unhinged. But once again, here they found this small for gestational age weight thing, which you see over here. So here's a difference, the most striking. So what we say is, what does it mean? We have to find it out. This doesn't resolve, but rather reignites a debate on the effect of epidurals on assisted delivery and instrumental delivery. And we will have to look again at that, and maybe some other data from other countries can help us. This is a study where 10,000 patients in Slovenia were compared in a single hospital who either received remifentanil, PCA, or epidural analgesia. And what they found in nulliparous and multiparous women, spontaneously, and in nulliparous women with induced labor, that the caesarean delivery rate and the instrumental vaginal delivery rate increased in the epidural analgesia group quite significantly. So this doesn't mean that remifentanil is superior in this regard, but it has its own safety concerns actually. But it does suggest that analgesic modality contributes to differences in delivery modes beyond case mix alone. And there is a Dutch saying, where there is smoke, there is fire. And we have to develop new tools and use new tools which might facilitate the study to study the effect of analgesia on labor and the efficacy of labor and on labor contractions. And in this regard, I'd like to mention an electrohysterography, which is an 80-year-old technique to make a sort of electric registration of the electric activity of the uterus, but which currently is being developed into a commercial used tool. And with these non-invasive surface electrodes, you can record the electrical activity of the uterine muscle. And what you can see, you receive the multiple registration planes, give also visibility of the propagation of the contraction. But in the complex algorithms, they are, they are added together to show us what's happening electrically, and it will help us answer mechanistic questions around epidural effects on labor. But until now, these data are not used for interpretations. The interpretation from electrohysterography comes from a complex algorithm which makes curves which are related to the Tocco curves obstetricians know, which can be used in clinical practice. But actually, the raw data will have signs to detect changes after interventions, either analgesic interventions or obstetric interventions like oxytocin increase. So this is an interesting path to follow the coming years. Now, coming back to epidural labor analgesia, there is a wide variety in the use of epidurals in Europe, as you can see. And there are some issues related to epidural analgesia, which have been resolved through the years, but there are still two things I want to highlight now in this specific lecture, and they have to do with the fever related to epidurals and with postdural puncture headache. So, talking about fever. Epidural-related maternal fever is an inflammatory process. Is this a myth, a truth, or misconception? Well, we called it historically fever, but actually it would be more correct to call it hypothermia, because fever implies that there is a set point elevation, a thermoregulatory change driven by pyrogens. And that might not be the mechanism in this case. It's a mechanistically neutral term as epidural-related hypothermia. It has implications for the diagnosis, how to manage the women and how we counsel them. Because if there's no infection, one should question if we should continue with antibiotics and sepsis evaluations in the neonate. It has been known since the late 1980s that there is a change in temperature in women who receive epidurals compared to women who received petidine, independent of infection. And while the classic febrile fever response involves endogenous parogens like TNF, alpha, interleukins, which circulate. This is something different maybe. It shares some features with inflammatory processes. Some cytokines have been detected, but the relationship is complex and the causal pathway remains debated. A fever is completely different than the hypothermia. And hypothermia, and that's where the current hypotheses are about hypothermia. Like I said, fever has to do with sterile inflammation, while the other hypothesis is that sympathetic blockade affects the cholinergic cutaneous vasodilation and sweating, which prevents heat loss during labor, which is a heat-producing process. It's like running a marathon. So why is this important? Because not only does maternal hypothermia affect maternal well-being, the fetus, which is still intra-abdominally, is affected. Because if you measure maternal temperature, either skin or oral or in the ear, the fetal temperature is often higher. So if we are satisfied with a maternal temperature of 38.5, it might well be that the fetus is experiencing a temperature of 40.0. So this is quite important. And there is this official, this physiological accepted standard that there should be a temperature equilibrium. So heat production should equal heat loss. And it's a balance between production, heat storage, heat loss. And a stress response is dependent on two main mechanisms: evaporation, sweating, and active cutaneous vasodilation to increase blood flow. And both of these mechanisms require intact sympathetic cholinergic signaling. And both are impaired by neuraxial blockade. And this is a physiological basis for the heat retention hypothesis. Now, this is a sort of schematic layout what happens. If you provide a spinal anesthesia for a C-section, when there is not increased heat temperature and the patient is thermoneutral, spinal anesthesia will cause active vasodilation and there will be increased heat permeability and loss, and there will be fall of of body temperature. When there is heat stress, though, in labor and heat is produced in abundance, then giving a neuraxial blockade results in active vasodilation, but also decreased cutaneous permeability, decreased heat loss, and a rise in body temperature. So there will be no sweating response and no active cholinergic cutaneous vasodilation. And the problem might be even bigger in cases where there is both infection, subclinically infection, and epidural hypothermia. And we know that the measurement of temperature during labor is widely varying between studies. Different thresholds are used, different routes of measurements, but there are estimates that the difference between significant hypothermia in epidural versus non-epidural range from 10 to 33% to under 1%. And this can be found consistent, this differently, and it's dose and duration dependent. So the conclusion is we should study this, not only because it has maternal impact, but it has also neonatal impact. And it has to do with extended, maybe inappropriate use of antibiotics. And the complex consequences for maternal hypothermia during labor is that there might be even neonatal neurological consequences. We don't know. But what we know from a study from Greenwell in pediatrics, where they looked in maternal epidural, I stated this wrong. We don't know it from this study. Greenwell looked at maternal temperature and related to these neonatal outcomes. And they found that the higher the maternal temperature was, the more significant the hypotonia, the assisted ventilation, and lower EPCOR scores occurred in the neonates. But this has not been proven yet for epidural-related hypothermia. And we base one of the good overviews produced in recent years is by Morton and Millington. They looked at the causal links between intrapartum epidural hypothermia and neonatal brain injury, and they concluded that there is insufficient evidence yet. But there is a causal link between epidural labor analgesia and hypothermia. And so we have to keep on looking for this answer of this. because the underlying mechanisms are not completely understood, and these clinical questions remain, and this is a main one. If we could make a distinction between epidural hypothermia from infectious fever, this would probably contribute to improved care for mother and child and improved interventions. A last slide, a recent study recently published where they looked at the cutaneous sympathetic blockade, what it did to the vasomotor and the pseudomotor response in women during labor. And if you can see, you have here the pseudomotor response in the hand and in the foot. And this is during the epidural labor portion, and the control group was a few days later, the same patients. And what you can see in all instances, the pseudomotor amplitude response was reduced during epidural analgesia. Not only in the foot, also in the hand, which was quite a curious finding, which might explain why 90% of body loss capacity of the body is lost when you give epidural analgesia. And the same for the pseudomotor responses. You see the same differences with here in the hand, and the vasomotor response in the hand. You see some differences which might have to do with effectiveness of the epidural analgesia catheter. Lastly, a new European study project is being developed, the EPITEMP study, which tries to detect differences in temperature trajectories between epidurals and infections, which might help solve these questions. The last topic I want to address is postdural puncture headache. Postdural puncture headache is said to be a spontaneous remitting headache, and which is caused to low CSF intracranial pressure. And actually, both of these statements are not true. By now, we know that many patients don't have a low CSF pressure while experiencing PDPH, postural headache, at least in the studies which have been done, and that's very few and not coming from anesthesia, mostly from neurology. But we also know that it's not remitting spontaneously or after a blood patch. First, everybody wants to know how to treat postdural puncture headache. Well, the evidence is minimal, but at least there are consensus practice guidelines, and which gathers the evidence which there is. And through this QR code, you can reach this evidence. But coming to the chronic psychological and physical outcomes of women after postdural puncture headache, you see there is a striking difference in a case control study from Israel, where they compared women who developed PDPH compared to a control group, and you see there is almost four times difference incidence of postdural puncture depression, postpartum depression, and post-traumatic stress disorder. Breastfeeding was lower. Women didn't want an epidural in future deliveries anymore, but also ongoing headache and backache. So PDPH does not cause just temporary headache. It shapes the entire postpartum experience, and its psychological footprint might be long-lasting. And we know this because there are there are groups on social media, self-support group, who take care of proactive support to one another, and these women have been addressed in a survey. These women were asked on social media to participate in a questionnaire, online, anonymous, and of these women, 30 were epidural analgesia patients, so mostly coming from epidural labor analgesia. And this study showed that women had actually still complaints after a year, more than 74%. And many of them couldn't even sit upright longer than 1 hour. So this is really serious damage. So our unintended accidental dural puncture causing PDPH results in chronic consequences in some patients. This is very alarming. And what they also did, they were checking how the disability and psychological burden was in this group. And if you look here using the Henry Ford Hospital Disability Inventory, actually 42% report severe disability and 88% report severe stress. So this is not subclinical. These are rates of psychological distress, which is actually an active mental health hazard. So we have to take this seriously. But we don't follow these women up. They have a PDPH, maybe they come back for a blood patch. And if it doesn't resolve, we refer them to the neurologist, and we often forget them. We shouldn't forget them. We should follow them up ourselves, because we still even don't know the exact causes, the exact mechanisms. Is it just a CSF loss through the spinal meninges, and it has to be persistent, or is it the traction on the meningeal membranes and vessels, or does intracranial vasodilation have to do with it? Well, I can give a whole lecture on this. I'll spare you the details because I think I passed my 20 minutes. There are many unresolved issues, and we have to resolve them, even though they are subclinically and they don't seem to be relevant statistically anymore. Where there is smoke, there is fire. And this means we have to address these issues in future research. Thank you very much for your attention, and I welcome your questions.